One of the hardest concepts in accountable care, which we hear all the time when we're talking to prospects about joining this mission, is they say, how can I be accountable for things that I don't control? I can prescribe the medicine, but I don't control whether the patient takes it. I don't control what the specialist does. I don't control what the patient eats. I don't control any of that. How can I be held accountable? I'm like, well, not you, then who?
Try to fix the current system or reimagine something new. Will healthcare ever serve consumers just like me and you? The power's in our hands, but every side's gotta come together. We want the newer generations to get something better. Until we flip the script and talk about what gets prevented. Until we see the changes permanent as if we meant it. Until healthcare is finally consumer-centered. We've got a lot to rap about.
Welcome back to the leading podcast about consumer-centered health. This is more than a show. This is a mission, y'all. As healthcare leaders, we're here to share with you the latest consumer-centered ways that healthcare is being designed, marketed, and delivered. And as consumers yourselves, we want you to understand how these options work and why they might be right for you and your loved ones. Here's what's going down today. First up, we have the Flava of the week about the rap remix in 26. Why does our show keep evolving, and how do we hope our new rap intro encourages you to champion the consumer point of view? I'll talk about that. Then we kick off the new year with Dr. Farzad Mostashari, co-founder and CEO of Aledade, who shares how they prevented 263,000 hospital and ED visits in 2025, other real results for value-based care, and why blood pressure control is one of his favorite KPIs. I'm Jared Johnson. Let's get it. Flava of the week. Healthcare is getting a remix in 26, starting right here with our brand new intro rap. Let me tell you about why the show continues to evolve, how the new rap reflects this latest evolution, and why our direction matters in the new year and beyond. First, why we keep evolving. In short, because of what we learn from our guests, the themes that emerge, and the trends that connect one dot at a time. This show will always spotlight the consumer point of view, and innovators are bridging the gap between traditional sick care and preventive well care. But what that looks like has changed. The limits of what can be consumer-centered in healthcare have come off, driven by GLPs and GPTs. And no, I did not need ChatGPT to write that line for me. But it's true that one of the earliest commissions of this podcast has been to drive healthcare organizations to provide experiences that lead to better engagement. That's what we've meant all along by consumer-centered, not getting lost in the technicalities of choice and payment structures, which are often where explorations of consumer transformation go to die. Where we've turned blue in the face, repeating that the consumer experience is much different and universal than the patient experience. And while we've continually pushed back on the notion that the pace of change up to this point is anywhere near enough to move the needle, at the same time, we've gained insights from speaking directly with hundreds of leaders and founders who've pointed to the opportunities for change much further upstream. And that's hopeful considering the reality that we can't place the full burden on providers when they only control a small handful of touch points in the first place. Meanwhile, the set of digitally enabled consumer health options expands by the day. Today's set of preventive tools includes wearables, longevity subscriptions, at-home diagnostics, and GLP-1s that put real choice into people's hands again. Not health care choices, mind you, but health choices. The types of choices are really evolving, from which doctor will give me the least crappy experience to which combo of weight management, digital primary care, and connected fitness tools will keep me out of the doctor's office in the first place. Second, the meaning behind the new rap. You may have heard, the new intro kicks off with a couple of legit questions that are harder to answer than they used to be. Do we fix the current system or reimagine something new? Will healthcare ever serve consumers just like me and you? The next two lines describe the urgency to act. The power's in our hands, but everyone's got to come together. We want the newer generations to get something better. The final section points to our mission. Until we flip the script and talk about what gets prevented, until we see that change is permanent as if we meant it, until healthcare is finally consumer-centered, and then it concludes with what we all know. Until those things happen, we've got a lot to rap about. Lastly, why our direction in 2026 matters more than ever. Here on the show, we've advocated for providers to meet consumers where they are. Well, it's taking a long time. We're seeing new waves of tools and services that can fill that gap, but most consumers still don't know about them or trust them yet. So we'll keep speaking to you as healthcare leaders by sharing the latest consumer-minded ways that healthcare is being designed, marketed, and delivered. And we'll also keep speaking to you as consumers yourselves so you understand how these options work and why they might be right for you. That's why this is more than a show. This is a mission, y'all. We challenge you to champion the consumer point of view even more to show the industry and consumers at large what the remix in 26 is all about. That's another way that we'll build the healthcare of tomorrow. And that's the Flava of the week. Hey, I'm here with my friend Carol Flagg from Healthcare Now Radio. Carol, you and I have an exciting new partnership that we want to tell people about.
Yep, we'll actually be launching an exclusive new opportunity called Limited Series. And these series will air nationally on Healthcare Now Radio, which, by the way, was named once again as one of the top 10 healthcare shows again in 2025, as well as here on the Healthcare Now Wrap. These series are going to cover some of the biggest topics in 2026, starting with rural health and including the CMS health tech ecosystem, GLP-1s, wearables, and more. So we're really excited about these series because there's a lot to talk about with these topics, which means they are ideal opportunities to create thought leaders in these spaces.
Yeah, Carol, that's what I'm the most excited about, is to really generate more informed, trusted information on these topics. And for those who are interested, spots are extremely limited for Q2 through Q4 of 2026. To get started, just reach out to either of us on LinkedIn, and we look forward to hearing from you. Hey y'all, I'm here with Israel Crush, founder of Hyro. Israel, what's an easy to understand example of how an AI agent can help consumers in their health journeys?
A simple section would be the fact that instead of enrolling into Medicaid and proving that you're eligible once a year, you need to do it once every 6 months. Patients don't know that. So we said, you know what, we're going to get ahead of that and we're going to educate patients about some of those changes and try to get them re-enrolled or redetermine their enrollment into those programs to make sure that one, they're covered, and two, that the health system gets paid or reimbursed for those patients. So I think that's like a clear win-win where you create an AI agent that is proactively helping both patients and health systems with issues that they face and make, again, the journey a little less complicated.
Thanks, Israel. Visit hyro.ai for more information. That's HYRO.ai. And tell them you heard about it on Healthcare Wrap.
The flow.
All right, everyone, let's get into the flow. We are starting off 2026 with a bang. Zane, wanted to welcome you back. Happy New Year.
Hey, Happy New Year. It's good to be here. We made it to 2026.
It's kind of wild, and I don't take that for granted that we made it to this year. 2025 was not my favorite year, so
No.
a lot went on, but excited to move forward. We're here with Dr. Mostashari, CEO of Aledade, and before we welcome him on, I'm curious what you want to hear from him. Definitely a couple things on my end that I'm hoping that we'll get to dive into, but like, what do you want to get out of this? What do you want to hear from him?
Well, so many thoughts. I mean, at the end of the day, I know on the Healthcare Wrap podcast, we like to talk about cool technology, like the cool stuff, the future-facing stuff, but at the end of the day, the backbone of healthcare, in my view, is primary care. And we all know that we need to move towards value-based care. And I think this is something that Aledade is doing squarely and has done it for a long time, and they know what they're doing. And so I'm hoping we should have a conversation and maybe for 2026 kind of reset the foundation around like actual healthcare. What are the things that need to happen? What is it that patients really need to receive to be able to be well? And what organizations need to do to compete in value-based care? And so those are the things that I'll be looking for. I don't think that some of those things will ever change. No matter how good the tech gets, it's still probably some of those core capabilities and outcomes that I'm almost certain Aledade can speak to us to that will continue to be important into 2026, 27, and into 2036. So that would be my perspective.
With that, let's welcome our guest and Dr. Farzad Mostashari, co-founder and CEO of Aledade. Welcome to the Healthcare Wrap.
Really happy to be here. Thank you so much.
It's truly an honor for us to have you join us today. And for those who are listening, what would you like them to know about you, about who you are, kind of what you do, maybe something that's not on your LinkedIn profile, or just kind of how you introduce yourself at a cocktail party or something as opposed to an interview?
Yeah, it's funny. I think some people are surprised at my trajectory, starting at a city health department and epidemic intelligence service officer, then federal policy, and then becoming an entrepreneur at age 45. And for me, though, those have really all been part of a one cloth. And it all has been kind of around a lot of this very same themes, honestly, back to med school, around how do we use, yes, technology, yes, digital health, but how do we answer the call of doing the most good for the most people? And it's been a career filled with optimism and frustration in equal measure. And I think many of us who are listening here can relate to that feeling of knowing that it can be better, being committed to making it better, but seeing all the obstacles that come in the way of what should be obvious. And I think the main realization that I've had is systems are resilient, and fee-for-service is a system. It's interlocking, it's care models, it's payment models, it's culture, it's institutional inertia, and they all reinforce each other. And if we really want to change healthcare, transform healthcare, you can't just add this technology or flip this payment model. You got to do it all. We have to do it all. We have to create an alternative system that can compete, that can fight against the dominant hegemony of fee-for-service and all the reactive, unsafe, unpatient-centered crap that we're all trying to fight against.
Well said.
The dominant hegemony. I love that. We're going to use that somewhere else.
We are nodding our heads because not just the fortune of those who we've had the opportunity to speak with here on the podcast, but our own personal beliefs from both of us, both having worked at provider health systems at various points and then working on the consulting side as well. For those who are less familiar with Aledade, maybe we can center ourselves a little bit on what the company does and why independent primary care is at the center of that model. And to Zane's point, I think we'll get to the opportunity to say, like, not everyone understands value-based care in the same way or to the same level. So maybe this is a good place to center our conversation.
When I was in the New York City Health Department, the mayor said, "Hey guys, over there," and I was running the health data shop at the health department, "How do we save the most lives?" And it's just such a freaking simple question, right? How do we save the most lives? And I was like, I don't know. No one had ever asked the question of me that way. And I looked in the literature and there was no paper that said of all of the USPSTF preventive services, good quality things we measure quality around and things that are evidence-based, like what actually would make the biggest difference in saving? And if you just pause for a second and think about that, everyone in healthcare is thinking about how am I going to pay my staff next week? But how many people are applying that same level of thinking to how do we save lives next week? What can we do to save the most lives next week? And that is like messed up, right? And so the answer to that was blood pressure control and is still to this day blood pressure control. And we do just as crappy a job controlling blood pressure today as we did 20 years ago. And like, what the hell? We know what to do to prevent strokes and heart attacks and kidney failures and blindness and all that. We know, and dementia. We know what to do and we just don't freaking do it. Why not? And I thought the answer to that was, all due respect to our health tech peeps out there, I thought the answer was technology. I thought the answer was we got to get everyone on an electronic health record with decision support and registry functions and structured data and decision support. Sounds familiar, right? And guess what? I got the opportunity to be a part of doing that. I became the national coordinator for health IT. And during my 5 years with the feds in Obama's first term, we got from 20% digital health to 80% of doctors having ambulatory EHRs with all the stuff to be able to control blood pressure. And they used it for billing. And they checked the box, including the box that said, share records with patient. They checked the box and they got the check, but they didn't change their business model. And so Aledade came out of frustration and optimism that if we could have a business model where you actually make more money preventing strokes than you do treating strokes. And I was like, where in American healthcare can I find a place where by preventing strokes, by controlling people's blood pressure and preventing strokes, managing care better, we can actually make money? And there was this thing called accountable care organizations that came out in 2012. And I was like, oh my God, this is it. And if you wanted to, first principles, set up a company to do this at scale, it seemed obvious to me you would work with primary care. They're the only ones in the system who actually have a job description that says prevent illness, don't treat it. And you probably would start with those who are not part of hospitals, where kind of the perspective is around hospitalizations, not around no hospitalization. I know how much we argue about like what the cost of, what the price of the fee schedule should be, but what is the right fee schedule for the stroke that shouldn't have happened, you know? So that's what Aledade is 100% focused on. All we do is we sign up primary care practices across the country. Most of them are independent, community-based primary care organizations and federally qualified health centers, multi-specialty clinics, solo docs, all the way up to some hospital partners. And we just focus on keeping people healthy and out of the hospital using technology, using, yes, machine learning and AI, using patient engagement techniques, using coaching, using contracts. But at the end of the day, our business model is if we can prevent strokes and hospitalizations, we get to keep some of it. And that is just revolutionary.
Love it.
Hey y'all, I'm here with Sina Arham, founder of Fridays Health. Sina, what do you think is broken in the traditional approach to metabolic health, and what are you doing to flip the script?
Let's be honest, the moment in metabolic health is being driven by the GLP-1 receptor agonist class of medications, right? We finally have something that is addressing metabolic health, obesity, and type 2 diabetes in an elegant fashion, right? It's efficacious, it's manageable for patients. And so I think we're having our moment in metabolic health in that the old guard of tackling metabolic health and obesity has a lot of stigma attached to it, a lot of shame and blame and guilt.
Thanks, Sina. Visit joinfridays.com for more information and tell them you heard about it from the Healthcare Wrap.
I was thinking about that adage that I hate in American healthcare called no margin, no mission. As a Canadian, when I first started working in US healthcare, I'm like, what is this? And people would say it in a positive way, like, hey, we need to earn a margin so that we can go on this mission to actually help people. And I used to think to myself, well, shouldn't the mission of the healthcare organization be to help people? And so I'd be curious. A lot of folks come on this podcast or on the conference circuit talking about value-based care. They're involved in value-based care in some way, at least they claim to. But in your mind, they don't typically perform really well in it, but in your mind, what are the core capabilities to actually deliver consistent results and actually do well within a value-based arrangement? What is it that maybe primary care physicians listening or health system people listening or even digital health people who are trying to think about getting into this, what do they need to do really well to say that they're performing within some of these contracts, so to speak?
We are doing well, you could say, right? Which in a system that's so bad, it's kind of impressive that we're getting 2% savings every year. So that accumulates, right? 2, 4, 6, 8, 10. And now a lot of we've been doing it for 10 years. And now a lot of our contracts, a lot of our accountable care organizations have more than 10% savings in a system that spends 5% on primary care, right? And so then it's like, well, how do you do that? What's the secret sauce? And I would say, let's take it from the clinical care and patient experience instead of talking to you about the technology, right? And then it'll be pretty clear to understand okay, you actually need a whole bunch of capabilities to support that. But fundamentally, something's got to change in care delivery if you're going to get different results. And so let me tell this story through the eyes of one 86-year-old woman with congestive heart failure who might or might not be my mom and who's getting care from a wonderful, the best primary care doctor you can possibly imagine, who is working within the strictures and constraints of a fee-for-service dominated academic medical center. You could not ask for a smarter human being, a more caring human being as her primary care doc. But when her primary care doc writes her a prescription for an SGLT2, which is the right medicine, and my dad goes to the pharmacy and the pharmacist says the metformin was $4, the Jardiance is $700 for the first month. As a Canadian, you're outraged. And my dad walked out.
Yeah, that's not a thing. Yeah.
He just couldn't bring himself to pay $700 for the first month. And I didn't hear about it. And her doc didn't hear about it, right? Because there's no real reason in fee-for-service medicine to pay a lot of money to set up a closed loop between SureScripts and the prescribing doc and have workflows and in the EHR to have an alert that says patient didn't fill this prescription and to have follow-up, which costs money on that. So then she has trouble breathing and it's getting harder and harder for her to breathe. And we called over to the primary care clinic and they really isn't an urgent primary care option. And the option is go to urgent care, not see your primary care doc who knows you for 30 years, who knows what's going on with you and could maybe increase your dose of Lasix and you'll be fine, right? but go to the urgent care clinic. It's never been easier. It's wonderful, right? We have these phones and we can get on a televisit with someone who doesn't know you. It's never been easier to do that. And it's never been harder to get a goddamn appointment with a primary care doctor. It's 4 months away. It doesn't matter if you're 86 years old and you have an EF of 18%. The next primary care appointment is 4 months from now. That's messed up, right? So you go to urgent care and the 25-year-old nurse practitioner there has never seen someone with an EF of 18%. And after sitting for 5 hours in the emergency room, you have the opportunity to go to the emergency room and sit in the emergency room for 40 hours. And sometime during your course in the emergency room, someone slides over a form and says, before we transport you, you have to fill out this form. You know what that form was?
I don't know. Who even knows? Probably medical history.
Before we transport you.
Payment. I don't know. Insurance.
Do you want your chest cracked? You want a breathing tube? You want a feeding tube in your nose? It's the advanced care planning document.
Oh, gosh.
That's the experience of healthcare today. And you ask yourself, could we make that a little bit better? Could we talk to people who have an EF of 18%? Who have congestive heart failure maybe before they have trouble breathing and are in the emergency room about what their end-of-life wishes are, and spend maybe, it might take 6 hours of conversation with them and their family. What are your real wishes? What are your preferences? In what situations you do want intense care and what situations you don't want it, right? And that might cost money. That might cost $1,000 that no insurance company wants to spend for 6 hours of conversation, but it might save $8,000 in end-of-life days in an ICU, right? And that's part of what we do. So those are some of the simple building blocks that we have put in place. At the point of care, we provide a 360-degree view of what's going on with the patient, including if they didn't fill up their prescription, or if they're seeing 12 specialists, or if they're overdue for some preventive service. If patients don't reach out to us, we reach out to them, right? Which is not a thing in fee-for-service primary care. You're just trying to fend people off. You're not inviting people in. Just trying to push people off, including people who really need to be seen 6 times a year. When you go to the emergency room, you get a call back. In fact, my mom this time did get a call when she went home from the emergency room. And I was like, this is amazing. Thank you so much. It was actually super helpful arranging her home, helping figure out how to get the right home care for her. And I said to the nurse, I said, is this a new service? She said, oh no, your mom's now in an ACO. And I was like, shouldn't everyone be in an ACO? Isn't this good for everyone to have a follow-up call after you go home from the ER? Right? So that's what accountable care is. It's not rocket science. It's what you would want for your mom.
When we say these big words, patient experience, consumer experience, value-based care, and we just talk about them so broadly a lot. And what a perfect example. This is about one person and their health and wellness journey, like one person at a time. That's what healthcare should be at all times. To that end, I'm familiar a little bit with a report that Aledade came out. I wonder if I can ask you about that. So this was your 2024 public benefit report. And there were a couple of big impacts in there that I just want to mention because I think it's tremendous. Preventing 263,000 unnecessary hospital and ED visits in a year.
Yeah.
That's on one end of the spectrum versus the other end of the spectrum that you're just describing on an individual basis. What else can you tell us from the report, or just like what results were you seeing from the report that maybe you're the most proud of, or anything else you want to mention from that? Because that's a big number, 263,000 unnecessary visits that were eliminated.
The public benefit report talks about some of the ways in which we try to be true to our values of service, good for the patients, good for the practices, and good for society, and being a great place to work. So that's our North Star commitments. The one that I'm maybe most proud of, the one page that I'm maybe most proud of, is blood pressure control. So we started off talking about the continuity, right? Between when 25 years ago I was asked, how do you save the most lives? And we have, as a top level corporate objective, there's like revenue and profit and growth and blood pressure control. Because I wanted it to be just up there just as much. And so in the last year in the Medicare Shared Savings Program, our blood pressure control in this sample of patients that were pulled was 84%. And where I trained at Massachusetts General Hospital, last time I checked, was 76%. And And our practices are community health centers in the Mississippi Delta. We do not have the resources that Mass General Brigham have,
Right.
but you can control blood pressure,
Right.
prevent strokes and heart attacks if you prioritize it just as much as you prioritize RVUs.
I've had the opportunity to work at the executive level of a number of health systems, working with boards and seeing what, call it the strategic scorecard is for some of these organizations. And I can tell you, blood pressure control is not on there, like not even close. And so I just think it's fantastic, almost culturally, that you all have a number that is so human that it would appear that you all can just rally around, which is a fantastic, I guess, cultural way to keep you all true to your mission. That's for sure. Curious maybe to take us in a bit of a different direction. As you all been on this journey, what have you learned about consumer health behavior that might maybe surprise some of our listeners or may not be immediately obvious based on how close you are to your patients?
One of the hardest concepts in accountable care, which we hear all the time, is they say, how can I be accountable for things that I don't control? I can prescribe the medicine, but I don't control whether the patient takes it. I don't control what the specialist does. I don't control what the patient eats. I don't control any of that. How can I be held accountable? I'm like, well, not you, then who? You want the insurance company to be in charge? Are they better situated than you are? You want the government? You want the lawyers? Like, who do you want? Who do you want to be accountable for ensuring that the right patient gets the right care in the right place? And it's that leap of saying, I don't control everything, but I'm willing to be accountable for what I can influence. And patient behavior is something that primary care doctors can influence, possibly more than anyone else in the system. When you hear the kind of relationship and trust and knowledge that our practices have with their patients, I mean, the average panel size is 2,000, and we regularly, I will pull up a list of patients and I'll start talking to a doc about their patients and I'll give them the name, and they will know out of 2,000, they will know them. They will know their history. They'll know their social history. And in part because they have this web of associations, because they know the patient's daughter, they know their husband, they know their mom, they've seen them in church, they've seen them in Walmart, right? It's not like a transactional relationship. And so I think the part that in terms of patient behavior and patient influence are almost 100% of what we take for granted almost is that transitive property of trust. The practices trust us, the patients trust the practices, right? And so we're able to offer a patient that 6 hours of conversation about their end of life wishes and get a plus 92 net promoter score, right? Whereas if Aetna called up my mom and she picks up the phone and says, "Hi, I'm calling from Aetna. I want to talk to you about your end of life wishes."
What can you tell us about where Aledade's headed for like the next 12 to 18 months or just short-term future? Kind of where are you focusing?
First of all, I love that you call 12 to 18 months short-term because that is how we think about it. And I hope we will always be thinking that 18 months is the short term, and what we're really focusing on is the next decade. We're 11 years in, and I think we have at least another decade of rapid growth ahead of us. And that's our kind of tagline is do more good. And that's all we want to do. We just want the opportunity to serve more practices, serve them better, serve more patients, do more good. And there's just so much opportunity for us that maybe the hardest thing is having the discipline to sequence all of that. And I think for the next 18 months, a lot of the effort we've put in the past 18 months has been around generative AI, basically standing up an amazing team of about 40 and 50 engineers who are almost replatforming our point of care tools to be not a single cloud-based instance, which was best of breed 2 years ago, but actually agents that live on the physician's desktop. That's clearly top priority for us because it really does transform our ability to kind of seamlessly provide insights at the point of.
If you don't mind me asking, are providers responding well to those tools? Do they see them as competitive?
Yeah, we have 95% acceptance rate of our AI tools. So we're live in over 1,000 practices.
One last question we always like to wrap with everybody is what gives you hope for the future of healthcare in our country? What gives you hope, like on a day-to-day basis?
Winston Churchill is quoted as saying, I'm not going to try to do the accent, Americans always do the right thing after they've exhausted all other possibilities. That's kind of how I feel like we are in healthcare and healthcare policy is we've tried like, oh, let's have patients have skin in the game and let's have high deductible health plans. And like, well, we can't squeeze more out of that stone. Let's just tweak fee for service. Let's do pay for performance on 127 quality measures. Like none of that works. And this is working. This giving primary care accountability for the total cost of care is working. And what gives me hope is the growing recognition of that and the consistency of that. There's been so much churn and drama when it comes to Medicaid and exchanges and Obamacare subsidies and vaccines. And there's just been so much churn. And one thing that's been the constant is I just saw the Dear Doc letter that Chris Klomp wrote out of CMS. And it says, we want more accountable care. And I think it's because it is that rare thing, which really is good for the patient and good for the practices and good for society. So I hope we can do more good.
Love that.
Perfect place for us to wrap. Really appreciate your time. Thanks for everything you're doing to make healthcare more consumer-centered. What a perfect mix. I heard more optimism than frustration, for the record, on that. And it's great to hear that. But thanks for joining us. We'd love to have you back soon.
Thank you both.